ग्रेट यार, अच्छा है।
हाँ।
और एक टॉपिक पूरा का पूरा आप कई वीक्स में कवर कर दोगे, बच्चों के लिए,
यस
पीजी के लिए, सबके लिए बहुत बढ़िया,
यस।
बहुत बढ़िया,
हाँ, राइट राइट राइट।
गुड इनिशिएटिव।
तो आपका क्रिकेट का क्या शेड्यूल होता है?
क्रिकेट आज अब स्टार्ट करना है, बस थोड़ा सा ना अभी बंद ही चल रहा है
ओके
प्रोग्रेस।
ओके।
Sir, good morning. It's 9 o'clock. Dr. Dinesh,
Yes,
please start the
yes,
session.
yes. We should start. Sorry,
Thank
Dr. Rawal, we are interrupting. Okay.
नहीं नहीं
So, good morning, everyone, and very warm welcome on the behalf of IIP Delhi office. Myself, Dr. Dinesh Goyal, Secretary IIP Delhi, and with me, Dr. Ajay Gupta is there. And this is our fourth session on celiac disease. And the renowned speaker and orator, Dr. Poddar, is with us. And we are very, very honored to have sir in this session. And for this session, we are also having two eminent personalities as chairperson, Dr. Manoj Rawal and Dr. Baljinder Kaur. Both are HODs of GMC at Sonipat and GMC at Patiala. And very renowned, I think, teachers of teachers, Dr. N.K. Roda is also with us. And we welcome you all. And with this, I pass this to Dr. Ajay Gupta to say a few words.
you, Dr. Dinesh. Welcome to this fine Sunday morning. I welcome all the delegates and the respected faculties. We are joined by Dr. Ujjal Padar and Dr. Manoj Rao right now. And we also thankful to Dr. Shyam Meena, who is coordinating this eGastro module. It has been going on wonderfully. And today we have chairpersons, Dr. Manoj Rawal. He is the head of the department at BPS GMC College for Women at Sonipat. This is the second women's college after Lady Harding Medical College for Women. And he was president of IAP Haryana in 2023 and is currently Central IAP member from Haryana. And we are also welcome Dr. Baljinder Kaur. She is the head of the department of the Government Medical College Patiala. She was the EB member from Central IAP from Punjab last year, and she was the EB member of SAPA and Adolescent Health Chapter. I request Dr. Manoj Rawal sir to please say a few words.
Thank you, Dr. Ajay, for a nice introduction. So, uh, a very good initiative by IIP Delhi, where they are starting the CU curricular class, and they will be having 4 lectures on celiac disease only. And I think the celiac disease is a tip of iceberg, where we are seeing lot of cases in pediatric age group. And my wife is a physician, and she was also sharing with me few days back that they are diagnosing lot of cases in adults also. So this is a disease which is missed in the pediatric age group, and then physicians are diagnosing in adults also. So it's a very good topic which have been chosen by for e-Gurukul class, and all of us will be uh, blessed to hear from Dr. Podar regarding celiac disease. And thank you so much, Dr. Ajay and Dr. Dinesh and Dr. Meena, for inviting me as a chairperson in this e-Gurukul class. Thank you.
Thank you, Dr. Rawal sir. We'll be joined by Dr. N.K. Roda shortly and by Dr. Baljinder Kaur shortly. I request Dr. Shamina to please introduce the speaker for the day.
Ma'am has joined. Dr. Baljinder has joined.
Dr. Meena, please introduce Dr. Baljinder Kaur. And I request Dr. Baljinder Kaur ma'am to please say a few words.
I'm very thankful to CIAP, IAP Delhi for inviting me as a chairperson to chair this session of celiac disease. As was being told earlier, everywhere, if you go in India, throughout India and abroad, you are going to encounter children with the celiac disease.
Voice नहीं आ रहा. Yes.
Am I audible?
Yes, ma'am. Please
Yes,
continue.
now. Yes.
So if you in any OPD, you see a number of cases of celiac disease, and hence it is very important that we have a talk and detailed talk by IAP Delhi for, I think, 4 master classes
This is the fourth master class.
dedicated to celiac disease only. So it will be beneficial to common pediatrician and to PGs, everyone. Uh, so hats off to you for arranging this. I think I will also be benefiting attending.
Thank you, ma'am. Thank you. I have one incident that I diagnosed one child as celiac disease, and subsequently his father and chacha, they were diagnosed as celiac disease in the adulthood. Now I request Dr. Meena sir to please introduce Dr. Ujjal Padar and proceed with the session.
Hello, very good morning to all. On behalf of Indian Academy of Pediatric Delhi State, very warm welcome to our uh, very well-known speaker, Professor Poddar sir, as well as our chairperson, today's session chairperson, Dr. Rawal and Dr. Kaur. And I would like to, thanks to my entire team of the IIP Delhi AEB members or office bearer, as well as indirectly supported from the my institute, my residents. They're doing the hard work to making the successful of this event. Now, without wasting of the time, I just a brief introduction of the today's speaker. Dr. Ujjwal Podar sir is a teachers of teachers. I earlier did the work in PGI Chandigarh as a student as well as a faculty. Then subsequently shifted in the SGPGI Lucknow. And sir, for the long time, sir held as a head of the department post. And recently on 31st, sir is superannuated from the SGPGI, and now, sir, in the last week, joined in the Calcutta as a Institute of IILDS for the welfare of our kids related to GI disorders. So, without wasting all the time, over to sir.
Thank you, Sham. Let me share my screen.
Sir, can you please increase your mic volume?
Request to our participants kindly put your queries on the chat box on the question answer part. Yes, sir. Visible.
Mic. Now audible?
Yes, sir.
Yes, sir. Better, sir.
Mic
you,
is okay?
Yes, sir.
Yes, sir. Now better,
It's
sir.
fine. Go ahead.
Thank you, sir. Please go ahead.
Right, sure. Okay. Can I start? Sham?
Please continue, sir. Please continue.
Okay.
Continue.
Thank you. At the onset, I must thank IAP Delhi for taking this initiative of e-master class. Special thank to Sham. Sham is is not a direct student, indirect student, but he's following me. Dr. Dinesh, Dr. Ajay, on behalf of IAP Delhi for making this platform. And today's chairperson, I am waiting for Professor Arora to join, NK Arora, and Professor Baljinder. Thanks, everybody.
Sir, please keep the mic close to your mouth. Your voice is intermittently down.
Okay, now this is
Yes,
clear
sir.
now?
Yes,
Okay.
sir. Okay.
Okay.
Yes, sir. Clear now, sir.
Right. So I've been asked to talk about celiac disease, special emphasis on diagnosis, management, and gluten-free diet counseling. As Sam said, I was in SGPGI till 31st of January. I have superannuated. So in the flyer said the professor head SGPGI probably little bit confusion. So I am no longer head. My current affiliation, nothing. I am on the road. However, from 1st of March, I will be joining this new institute. Not new, it is a decade-old institute called Indian Institute of Liver and Digestive Sciences, Kolkata. It is basically a no-profit, NGO-run philanthropic institute. So I want to give back something to my state. So that's why I decided to join the institute. Let's start the topic. What is celiac disease? Basically, it is a disease of the proximal small intestine. Remember, it doesn't start from the colon. It always starts from the proximal small intestine. It is characterized by abnormal intestinal mucosa associated with permanent intolerance to gluten. So, what does it mean? There is a permanent, this is not a temporary. People believe that food allergy is a temporary, but the celiac disease, intolerance to gluten is permanent. and there is an abnormality in the intestinal mucosa. So what is the pathogenesis? This is called basically gene and grain theory. There is a gene and there is a grain. So it is the result from inappropriate immune response against gluten in genetically predisposed people. So you need to have genetic predisposition to develop celiac disease. Then only you do. Keep on eating chapati is not going to make you susceptible for celiac disease. You need to have that gene. That's why it is more common in North India than South or Eastern part of the country where genetic predisposition is less common.
Sir,
Now,
your voice is intermittently cracking. Kindly keep the mic close to your mouth.
okay, Sham, thank you. Now,
Yes, sir. Fine.
uh, so genetic susceptible host, for some reason, it is not that all the people who are genetically susceptible are going to develop celiac disease. Obviously, there is a gene dose phenomena. Those who are having the significant mutation or there is the multiple gene is playing together, they are more susceptible. However, probably some environmental factor predisposes them to develop hypersensitivity to gluten and then immune-mediated inflammatory injury to the small intestinal mucosa, and as a result of its end result, which we see this malabsorption syndrome. Sam, the voice is clear now?
Yes, sir.
Okay. So what are the genetic factors? Mainly it is a HLA-DQ gene, DQ2, DQ8, which is seen almost 99% cases of celiac disease. However, 30% of general population also harbors this HLA. So it is not that only HLA predisposition is going to give rise to celiac disease. I'll come to that later. Now, how do we diagnose celiac disease? There is the two kind of thing. One is the old and new. Initially, the modified ESPGN criteria, we used to say you need to document there is a small bowel intestinal abnormality like villus atrophy on biopsy, and then you show unequivocal clinical response to gluten-free diet, which comes in weeks' time. But the new diagnostic criteria, which has come in 2020 by ESPGN, that said you may not need to do duodenal biopsy. You show the tissue transglutaminase antibody is more than 10 times. In addition, there is anti-endomysial antibody positive. Then without biopsy also you can make a diagnosis of celiac disease. However, diagnostic confirmation comes from response. Just showing TTG elevation and gluten-free diet is not enough. The patient came to you with symptom. That symptom has to subside. And that response comes promptly, unequivocal response. That is a universal factor for both old and new diagnostic. So, what is that the trick? Trick is that who detects celiac disease? This is you, the pediatrician, physician, uh, whoever practicing in the periphery, they detect celiac disease by doing this serology. Most of the patient comes to a gastroenterologist after this celiac serology is done, and many of the time the patient is being referred after starting gluten-free diet. That creates problem. I will highlight later. So basically, who diagnose? Detected by pediatrician. For diagnosis, I believe we need the biopsy. So it is a gastroenterologist. But the confirmation again comes from the pediatrician who have sent the patient to a gastroenterologist who did biopsy, and patient has gone back to the pediatrician, and he will document there is a unequivocal clinical response to gluten-free diet. Then only you are sure this is a case of celiac disease. So this is the modified SPAGAN criteria to diagnose how do we approach a patient with celiac disease, which came in 2020. When you are clinically suspecting celiac disease, the child has come to you with chronic diarrhea, failure to thrive, anemia, which is the classical presentation, or there is a short stature, or there is a iron deficiency anemia, or you may have a subset of patients who are high risk for celiac disease, who are screened, like diabetes mellitus, autoimmune diseases, hypothyroidism, Down syndrome, Williams syndrome, IgA deficiency, or family member is having celiac disease. So these are the risk group where you have may do a screening, or celiac serology was done for any reason, like point of care test in the community or DGP test done, and any of these tests then there is suspicion of celiac disease. So what will you do? First thing you are supposed to do TTG antibody along with that total IgA. Now, after getting the TTG report, you'll decide what to do. If the TTG report comes more than 10 times upper limit of normal, that varies from lab to lab. Some lab may give 5, some lab say 10, some lab say 20. If the upper limit of normal of that lab cutoff is 20, then it has to be more than 200. So 10 times upper limit of normal, then what will you do? You give this option to the family. They see, we can make a diagnosis of celiac disease without biopsy, provided you agree to go for a anti-endomysial antibody test for a separate sample, not the same sample. So if anti-endomysial antibody is also positive, then you can make a confirmed diagnosis of celiac, right? Now remember, just TTG alone is not enough. You need to get the EMA test also done. Now you got a TTG test report has come less than 10 times. It is positive, but 10 times upper limit of normal. You are suspecting this is a celiac disease. So what will you do next? You need to do duodenal biopsy to show villus. The other situation may be you got a TTG which is more than 10 times, but endomysial antibody is negative. Again, you have to do duodenal biopsy. Situation 3, where you are clinically suspecting this child must be having celiac disease. However, his TTG report was negative. So why TTG negative? It may be falsely negative because of underlying immune deficiency. There is no antibody production. There many times the low gluten intake gives rise to a very low titer of TTG, may not be positive. In that case, you need to do HLA typing. HLA DQ2, DQ8 will help you to decide where you are clinically strongly suspecting celiac disease. However, TTG is not negative, then that might help you. And negative TTGs may be because of low antibody titer, immune deficiency, extraintestinal manifestation, not the diarrheal type and low gluten intake, then HLA. Now, if the HLA DQ2, DQ8 comes negative, see, HLA has got a very high negative predictive value, almost 99%. It rules out celiac. If HLA DQ2, DQ8 negative means there is no celiac. However, if HLA DQ2, DQ8 comes positive, then that is not diagnostic of celiac. Then again, you have to do biopsy to document villus atrophy to say celiac disease. Other situation may be there is a no risk factor to have a negative TTG and IgA level is also normal. You are clinically strongly suspecting celiac disease. In that case, there is a no risk factor, IgA normal, so there is a no celiac disease. TTG negative means it is not celiac. It has been shown that IgA deficiency is more common in celiac disease patients, and that's why the recommendation is that you do total IgA level same time at the time of TTG to avoid confusion. However, in day-to-day practice, if you go for a TTG only, it makes sense. You will save money. Just TTG is high. Why? What is the need of IgA? No need. When you are suspecting celiac disease, TTG has come negative, that time you can add IgA to see what I am suspecting celiac disease is maybe because of low IgA, you are not getting TTG positivity. And if it is comes out to be IgA deficient, which is seen in 2 to 3% of celiac disease cases, then you have to do IgG TTG or DGP test. If any of these are positive, you go for biopsy. So this is the algorithm you are supposed to follow. So clinical suspicion, go for TTG. TTG is more than 10 times. Get endomysial antibody. Without biopsy, you can celiac disease. However, practically, EMA test is either not available or is very expensive. So it's better to send the patient to sham to get a duodenal biopsy done and to confirm the diagnosis. This is a very simple algorithm for adults. You know, we as a pediatrician, we are very restrictive about putting our patient for endoscopy, or we have some some kind of fear. In adult, it is very simple. They divided the patient into two groups. Is this patient who has come to you on gluten-free diet or is on normal gluten-containing diet? So if the patient is already on gluten-free diet, started by somebody else, by peripheral physician, pediatrician, then they ask for HLA testing. If this HLA testing negative, there is no celiac disease. If HLA is positive, then you go for gluten challenge because already patient is on gluten-free diet. So obviously your doing biopsy will not give the diagnosis. You need to give challenge to make a diagnosis. Challenge negative, no celiac, positive is celiac. Patient is on gluten-containing diet and suspected celiac, same policy, do TTG, IgA, TTG positive. If it is in children, obviously we have the option of keeping for adult. But for adult, they say TTG positive, go for biopsy. No need to do another antibody to confirm the diagnosis. Now, biopsy showing celiac disease, celiac disease. If there is a biopsy normal but TTG positive, then it is a potential celiac disease. He has a chance of developing celiac disease, needs to be on follow-up. If you have a TTG negative, then it is celiac is unlikely. IgA deficient, same policy doing DGP or IgG, TTG and biopsy. Now, what is the role of HLA? HLA in adult people, they are relying heavily on HLA, but in pediatric algorithm, I have shown you the HLA is done only a subset of patients where you are suspecting celiac, but TTG is negative because of immune deficiency, etc. There, HLA might guide you whether to go for biopsy or not, because the HLA prevalence is very high, DQ2, DQ8 among celiac, almost 99%. Simultaneously, in general population, HLA DQ2, DQ8 prevalence is 20 to 30%. What does it mean? It means it has got very high negative predictive value. If HLA DQ2, DQ8 is negative, then 99% assurance this patient is not having celiac. So you need not to do anything. You just say there is no celiac disease, no need to do biopsy or challenge anything. However, it's positive. Test doesn't give you a guarantee this is celiac. So you cannot use HLA to diagnose, but use HLA to rule out celiac. Meena has asked me to present some cases. So I have taken some interesting cases which we have seen here in SCPGI, my previous department. This boy was 11 years old, male, who came to us with history of diarrhea for 15 months. 11 years old, he was otherwise asymptomatic. For last 1.5 years or so, he's having diarrhea 3 to 4 times per day. However, volume is small, mainly postprandial diarrhea. No nocturnal diarrhea with mild periumbilical pain. He does not have failure to thrive. Remember, triad of celiac disease is diarrhea, failure to thrive, anemia. So we neither have failure to thrive, no anemia, no abdominal distress. On examination, his anthropometry is relatively preserved. Weight 82%, height 94%. He didn't have any pallor. Abdomen was soft, not distended at all. But he came with a history of chronic diarrhea of 15 months duration. Elsewhere, 1 year back, 1 year prior to coming to SGPJ, he was investigated. He is found to have normal hemoglobin of 12. However, his TTG IgA was positive. It is more than 10 times. It was 88.7 with a cutoff of 5. So, common thing comes for celiac disease, and in the periphery, without doing anything further, this child was started on gluten-free diet 1 year back. So, for 1 year, he's on gluten-free diet. However, he didn't show much response. He continued to pass 3 to 4 small volume stool, mainly postprandial, no nocturnal diarrhea, etc. So what will you do next? Now he has come to you for the confirmation. Is this child is having celiac disease or not? He is already on gluten-free diet on the basis of TTG report only. This is not uncommon. I'm sure Meena, Sham and other people have encountered often this kind of patient. So after 1 year when he came to us, though he had a poor compliance, but he started gaining weight. In 1 year, he gained 2 kilos. Remember, he's 11 years old child. in a year 2 kilo weight gain should be adequate. He gained 5 centimeter height, no pallor. We investigated his hemoglobin, same 12. His stool examination revealed giardia. When we repeated TTG, it is negative. What does it mean? His TTG was positive 1 year back. You cannot say that that report was wrong. This child is on gluten-free diet for 1 year. Usually 6 months to 12 months is a time frame. By the time TTG will become negative on gluten-free diet. So you cannot say that since the TTG is negative, no celiac. It may be the effect of gluten-free diet. We did the duodenal biopsy, which is normal. Again, the biopsy may be normal because of gluten-free diet. So that is also not going to tell you that he doesn't have celiac disease, right? So in this situation, what will you do? Remember, this child is 11 years old. So he has a optimum time to go for gluten challenge. So we did gluten challenge to find out is he having celiac disease or not. His biopsy was normal, TTG was negative, he is 11 years old boy. So 3 months of full gluten exposure, there is no exacerbation of symptoms. In this 3 months, he gained 1 kilo, hemoglobin remained same level, TTG repeated after 3 months negative, we repeated biopsy, is normal. So what does it mean? It means his gluten challenge is negative. So he doesn't have celiac. He had a giardia in the stool and duodenal biopsy. His symptom was suggestive of irritable bowel syndrome. He had postprandial diarrhea with pain. Probably now I can claim his initial CTG report was false positive. So this case highlights the role of challenge in proving or disproving celiac disease. Now going to the next patient. So before that, how to confirm celiac disease when patient is on gluten-free diet? This is a common problem now. We keep getting patients in the periphery. Somebody got a TTG done, started on gluten-free diet. After 6 months or 1 year, he will or the patient himself will come to confirm, am I having celiac disease or not? Now, this is the time frame. If you repeat the serology, TTG, 80% on strict gluten-free diet become negative by 6 months to 12 months. So when the patient comes to you after 6 months, very difficult to interpret repeat TTG level. Negative will not tell you that this is the effect of gluten or the initial report was false positive. Mucosal healing, when you do the repeat duodenal biopsy, almost on gluten-free diet, 95% cases you will get a normalization in 2 years' time. It takes longer time for normalization. However, a proportion of patients may still have duodenal biopsy abnormal on gluten-free diet. HLA testing, already I said that it has got negative predictive value, no positive predictive. So what option do we have when patient comes to you on gluten-free diet? So HLA DQ to DQ weight is very good test to rule out celiac disease. Positive test cannot say it is celiac disease. You need to wait for 2 years or the right age, at least gluten-free diet for 2 years, because you need to document that there is no villus atrophy and then exposed to gluten and show there is a deterioration, then only you can do gluten challenge. So we have option of HLA testing and gluten challenge to prove or disprove. I showed a case where gluten challenge helped. Now I will show you the role of HLA. Indication of gluten challenge a little bit. You need to have, these are the indication, like when biopsy was not done, like the case I showed, who was diagnosed as celiac disease just on the basis of TTG, came to us after 1 year with a normal TTG, normal duodenal biopsy. So there, it helped. Baseline biopsy was done, but it was not characteristic. It didn't show villus atrophy at all. Baseline serology not done or was negative, and patient was not IgA deficient and diagnosed before 2 years of age, when chances of getting negative serology or abnormal biopsy because of something else is very high, because the other causes of villus atrophy is more common in first 2 years, especially infection and allergy. And adolescent boys and girls, very common on celiac disease, diagnosed celiac disease on gluten-free, they want to give up because they say that I had enough, now I will start. So there you need to give challenge to document them, yes, you can start or you cannot start. Remember, in pediatric practice, there is a window period. Adult practice is very simple. There is no age bar for giving challenge. So patient comes to you, you do that HLA and go for challenge. But for us, you cannot do challenge before 7 years of age because then it might impact the dentition, and you cannot do after 12 years because it can impair the pubertal growth part. So this window period is between 7 to 12 years. The case I showed, he was 11 years, he was in the window period and we managed to do it. Now I will, and the method of gluten challenge is not difficult at all. You need to document like the case I showed, negative serology, normal duodenal biopsy. Then put this child on gluten, full gluten 3 to 5 gram per day. Remember, one slice of bread is equivalent to 1.5 gram. So we need to have 2 to 3 slices of bread per day. Repeat serology and biopsy after 12 weeks. See, remember, the positivity or negativity of challenge depends not on serology, it depends on the biopsy change. There has to be deterioration or showing abnormality in the villi structure with or without serology positivity or symptom, then it is a challenge positive. Coming to next case. This was a 4-year-old girl who came to us with a history of diarrhea for 9 months. 4 years old, 9 months history of diarrhea, chronic diarrhea, small bowel type, large volume stool, offensive, outflowing, no blood mucus. See, this girl was seen by an adult gastroenterologist elsewhere. He asked for endometrial. It is a 10 years back, so endometrial antibody was easily available that time. And he got a anti-endometrial antibody positive. And this child, without going for biopsy, this started on gluten-free diet. She was for 6 months on gluten-free diet. She had some equivocal response, not unequivocal. Some improvement, but not clearly. Now presented to us after 6 months on gluten-free diet. So what will you do next? So we on gluten-free diet, this child hemoglobin was normal. We repeated TTG, not EMA by that time was not available. It was negative. We did endoscopy, showed normal villi. Now, father wants to know, she is case of celiac disease? Doctor, my daughter was having diarrhea. Somebody started gluten-free diet on the basis of anti-endometrial antibody. After 6 months now, you are saying his TTG is negative, biopsy normal. Still, there is possibility that this child is having celiac. So in the algorithm, what will you do next? Remember, this child is 4 years old. Biopsy may be normal after 6 months, a fraction of patient on gluten-free diet. TTG may be normal after 6 to 12 months of gluten-free diet. So neither of these can prove or disprove the diagnosis of celiac disease. Since this child is less than 7 years, you cannot do challenge. So what is left with? I said that the 2 tests which helps you to go further. One is HLA testing and challenge. So challenge is out. So what is left? HLA testing. So we got the HLA DQ2 done, which was positive. As I said, HLA DQ2 positivity does not give you guarantee this is celiac disease. Negativity definitely. So what we did? There is we couldn't do the challenge in this child. She was 4 years old and the time was not right to do challenge as well. So we kept this child on gluten-free diet and we were waiting till she becomes 7 and we can give challenges. Probably this child is not having celiac disease, but at this stage you cannot say that she does not have celiac disease since the initial test was anti-endometrial antibody where chances of false positivity is very low. Coming to, so this is another patient, 4 years old boy. This child was from UP migrated to Karnataka in Bangalore. The main complaint of this parent was failure to thrive. He's not gaining weight for the last 1 year. His weight at 1 year of age was 9 kilo. At 3 years of age, 11 kilo. It is not so bad. But parents have a perception that my child is not growing well. This child did not have any diet, just failure to thrive. And the pediatrician in Bangalore, actually, he was trained in PGI. That's why he knew about this celiac disease. So 1 year back when this child presented to him, so he asked for TTG. So the commercial lab given the report of 41. This is not 10 times more than upper limit. His hemoglobin was 14. This child had just failure to thrive, no diarrhea, no anemia, but TTG came positive. So the pediatrician put this child on gluten-free diet 1 year back. So after 1 year of gluten-free diet, he came to us. He didn't have any symptoms, just failure to thrive was symptom. In 1 year, he gained 1 kilo and his height was normal, no pallor. So what will you do next? This is again a 4 years old child. So on gluten-free diet. So doing serology is not going to help, probably doing biopsy not going to help, and you cannot do challenge in this patient. At SGPGI, 1 year after gluten-free diet, we repeat the TTG, which was negative. His hemoglobin was 13. Here, instead of going for biopsy, we decided, because our suspicion was very weak. This child probably was not having celiac because there is no diarrhea. You remember, the younger is the child, more chance of having classical celiac disease, diarrhea, predominant celiac disease. So we asked for HLA test. Now HLA helped. In this child, HLA came negative. Our suspicion was already weak. So we said this is no celiac. We started this child on gluten, and 3 months on full gluten diet. He didn't develop any symptom. TTG remained negative. So these patients highlight the role of HLA. HLA, when the patient comes on gluten-free diet, and probably the TTG was falsely elevated at 45. So diagnosis of celiac disease with certainty. You need to have a serology. Can you guess what is this test? This is endomycin. Nowadays we don't do it. In SGPJ we used to do it 10 years back. You need to have endoscopy and biopsy showing the urinary villus atrophy. So after adding serology and biopsy, we said yes, 1 plus 3 is 4, means serology plus biopsy. 1 plus 1 is not 4. So just serology without biopsy is not celiac disease. So we put the patient on gluten-free diet. So far, so good. So the treatment, once you diagnose celiac disease, treatment is very simple. The gluten-free diet. But it is easier said than done. It is a lifetime commitment. As I said in my first slide, this is a permanent gluten intolerance. A patient, you cannot keep that after 2 years or 3 years, you will start the patient on a gluten again. So it is lifetime commitment, more expensive. It limits the patient socially. They cannot, it's difficult to attend marriage or birthday party where everybody is eating gluten-containing diet. So diagnosis needs to be established before putting the patient. The cases I showed, very common to see this kind of patient, the pediatrician or physician starting gluten-free diet without thinking that is it really a celiac disease or not. So obviously you need to restrict the wheat rye early. Oat initially restricted, now after 1 year you can start. Initially the patient, especially diarrhea, predominant celiac disease, when they are having malabsorption, sometimes they have lactose intolerance, you might have to restrict the dairy product. And remember, the gluten-free diet is poor in minerals, fiber, and water-soluble vitamins. So you need to supplement them when the patient is on gluten-free diet in long-term. Now, how often what is the timeline for response? Usually, as I said, there should be unequivocal clinical response in weeks' time. See, there is a dramatic response. You put the patient on gluten-free diet, 70% will have symptomatic improvement within just 2 weeks. Diarrhea usually passive by 1 week, steatorrhea passive by 2 weeks. They will have catch-up weight in 6 months and catch-up height in 12 months' time. Now, next 10 minutes, Sham, can I take 10 minutes more?
Yes, sir. Go ahead. Go ahead.
Okay.
Go ahead.
Okay. So if the patient, you started on gluten-free diet but not responding, so what will you suspect? Non-responsive celiac disease is defined as 6 months on gluten-free diet not responding. Commonest and the most important cause is incomplete adherence to gluten-free diet. Other unusual causes not seen commonly in children are maybe associated IBS, lactose intolerance, microscopic colitis, etc., not seen in children. bacterial pancreatitis. These are all absolutely extremely uncommon causes of non-response. Non-response is predominantly it is because of compliance issue. And another entry called refractory celiac disease. So, and after 1 year of strict gluten-free diet, no response, it is extremely uncommon. Just few case reports are there, but it's not an entity we encounter as a pediatrician. So how do you do a follow-up? Once you put the patient gluten-free diet, do frequent follow-up to start with, maybe 3 monthly, till his symptoms subside, his TTG become negative, and our blood tests are become normal. You need to monitor anthropometry, do the CBC and LFT if it is normal, and consider doing a thyroid function test one. So what is our expectation when you do follow-up? You want the patient should be symptom-free. The patient came with particular symptom on gluten-free diet, symptoms should be relieved. There will be normalization of the lab parameter. Abnormal hemoglobin should be normalization. And you want the serology to become negative. TTG was positive, become negative. You monitor growth. Monitoring anthropometry is very important. But what is the ultimate goal? You are treating a patient for a disease. What is the disease? Disease is not TTG positivity. Disease is in the intestine, where there is a villus atrophy, which is causing all this problem. So, ultimate target of treating celiac disease should be mucosal healing. This mucosal healing term we use while treating inflammatory bowel disease. You want to remove all sorts of inflammation to prevent complication. The same thing is applied in celiac disease. If you don't achieve mucosal healing, the risk of developing long-term complication will remain. That I am going to highlight. Now, this is a landmark study. This study was published 2013 in Annals of Internal Medicine. They collected data from 28 pathology departments of Sweden between 2006 to 8. So they wanted to show the risk of lymphoproliferative malignancy, which is very high in celiac disease, vis-a-vis persistent villus atrophy. So what they did, they have collected 29,000 patient data, and follow-up biopsy, out of which follow-up biopsy was done in 33%. So these are 9,700 patients had a 2 biopsies, baseline and follow-up biopsies. And most of the, and so they ruled out these cases where biopsy was done too early or too late to look for, or lymphoproliferative malignancy already developed. So the study population was 7,265, out of which 43% had persistent villus atrophy. And if you see the patient population, in the 46% are pediatric patients in this cohort. Follow-up biopsy was done predominantly after 1 to 2 years, 46% of the cases, and median follow-up period was after biopsy 9 years. So coming to the result, out of the 7,000 patients, 43% had persistent villus atrophy, and rest 57% had complete mucosal healing. So now they have compared the two cohorts. One who have continued to have villus atrophy because of this poor adherence to gluten-free diet, and another has a complete healing. Overall lymphoproliferative malignancy, 53 patients developed over 5 years after follow-up biopsy. Standardized incidence ratio was 2.8, significant. Now you compare these two, mucosal healing versus persistent. Standardized incidence rate was almost 4 times more chance of developing lymphoproliferative malignancy in those patients who continue to have villus atrophy than who has complete healing. Hazard ratio was high, and when there is a severe villus atrophy, the risk is almost 4 times. If you see the risk of lymphoproliferative malignancy, in those cases where you have achieved mucosal healing, it is not significant. The incidence ratio, standardized incidence ratio is 1.5, but 95% confidence interval going both sides of the zero. That means it is not, it is equal to general population. Chance of developing lymphoproliferative malignancy means either small bowel lymphoma, carcinoma, etc., is almost equal to general population when you achieve mucosal healing. However, it is almost 4 times higher than general population when continue to have villus atrophy. So mucosal healing reduces the risk of lymphoproliferative malignancy in celiac disease. Another study which is relatively recent, 2023, published in Gut. This is the data from multiple centers from UK, Sheffield, Italy, Boston, USA. Now in this cohort, they collected the data of patients who underwent biopsy twice, and they wanted to see what is the impact of persistent villus atrophy on long-term outcome. So total 2,000 plus celiac disease patient follow-up biopsy was done in around 700. So 32% of celiac population, these are adult disease, follow-up biopsy done. The complication, they wanted to see the complication. What complication, long-term complication you want to see? Refractory celiac disease, which are two-type refractory celiac disease. 1 and 2, ulcerative jejunoileitis, abdominal lymphoma, small bowel carcinoma. Previous study showed lymphoproliferative malignancy. Here, they included everything, including refractory celiac disease, ulcerative jejunoileitis, which is basically a predisposing factor for lymphoma, abdominal lymphoma, and small bowel carcinoma, and mortality. See the outcome. Persistent villus atrophy means they have a MARS grade 3 A, B, or C was 22%. Previous study showed it is 40%. Here it is 22%, and rest 77% had mucosal healing. Now, when you compare that, overall complication rate was 6.3% and 4.6% has death, but complication rate was 21% when there is a persistent villus atrophy versus just 2%. Hazard ratio was almost 10, means developing complication in the form of refractory celiac disease, ulcerative jejunoileitis, lymphoma, carcinoma. This is almost 10 times higher in those patients who are continued to have villus atrophy than who achieve mucosal healing. So again, the deep mucosal healing decreases the risk of complication and mortality in celiac disease. So what is the basic story? Basic story is to achieve mucosal healing. Now, how we are going to achieve mucosal healing? By ensuring that adequate compliance to gluten-free diet. Now, these are the studies we showed. Overall, almost 1/3 of the patients, they continue to take gluten. So there is compliance issue is the problem in 1/3 of children. This figure is 22% in this meta-analysis of 49 studies. Now, question is how to check compliance. When the patient comes to you in the OPD, then mainly we rely on dietary questionnaire. What we do serology, we repeat TTG. We don't do repeat biopsy often. And this is a new test called gluten immunogenic peptide that I will talk later. Now, basically, the serology is not a very good marker to decide whether patient is having poor compliance, good compliance. But mainly, it is a dietitian taking the history about using questionnaire is the best way to detect whether the patient is having good adherence or poor. This is our study published recently in the month of August in JPJN report, where we have looked at the compliance issue. It is mainly dietitian who has taken the detailed dietary history, and what we have seen out of this 103 children, 50%, almost 48.48%, they have a good compliance, but poor compliance was seen in 52% of the children. But very interesting part, when dietitian who is trained in giving counseling for celiac disease, he is counseling this patient. After 6 months, when again we have interviewed, we have seen this poor compliance or lack of non-adherent has decreased. More and more patients become adherent. From 48%, it becomes 64%. Now, what about we do keep doing serology every 6 months, 1 year? You do TTG. How good is the serology as a surrogate marker for mucosal healing? I said that ultimate goal is mucosal healing. So you want to see serology is negative, so you are happy. So remember, while patient is on gluten, means taking gluten, serology is excellent in predicting whether there is a villus atrophy or not. But when the patient is on gluten-free diet, this is not a good marker to decide whether patient is having mucosal healing or not. This is a very elegantly conducted study, and on the basis of this study, this 10 times upper limit of normal of TTG report came. They clearly showed the correlation between TTG titer and villus atrophy. See, if the patient is having Mars grade 3, all of them are having more than 10 times upper limit of normal TTG. So, very high TTG, very good correlation with villus atrophy. So, serology is good to say when it is positive that the patient is having villus atrophy. However, as a proxy of mucosal healing, serology is not good when the patient is on gluten-free diet. This is a landmark study published in Gastroenterology 2017. This is a meta-analysis of multiple 26 studies. It's a huge database. TTG serology done repeatedly in more than 1,000 patients, EMA more than 1,000 patients, and they decide villus atrophy Mars 3, and what they have shown, the persistent villus atrophy, again, the figure is around 38%. It is a more in adults to have persistent villus atrophy than in children. Figure is around 20% in children after 2 years of starting gluten-free diet. Now, positive serology predicts persistence of villus atrophy when you are using TTG in 83% of the cases, when you use EMA 90%. What does it mean? A patient comes to you on follow-up on gluten-free diet, you got a TTG which is positive, that means patient is having villus atrophy, persistent villus atrophy. He has not achieved the target of mucosal. However, what we are looking for as a clinician, we want to see it become negative. When negative serology, you do the biopsy, you will see half of them are still having villus atrophy. So this serology is not a good surrogate marker for mucosal healing. So we should not heavily rely on serology. Yes, like HLA, we tell you HLA DQ2 negative means no celiac. Here, positive serology will say this patient is non-compliant, he is going to face problems. So follow-up duodenal biopsy should be ideal, but it is practically not possible. So what is the best biomarker for mucosal healing? So this is the new marker. This is called gluten immunogenic peptide. See, there is a peptide in the gluten which is not normally digested by our human system. We don't have enzyme system to that. That is called GIP, gluten immunogenic peptide. Some of it is absorbed and passes through the urine, and mostly it passes through the stool. That can be detected by this monoclonal antibody test. Both whoever is taking gluten, he is going to have GIP in urine or stool. In healthy individual who are taking gluten, GIP means gluten immunity comes to within 4 to 6 hours. You can detect either in the urine or stool, and it remains in the blood for 1 to 2 days. Celiac disease patient not taking gluten and there is no villus atrophy, you don't get any GIP. What does it mean? GIP is from the gluten. If somebody is taking gluten, you will get this gluten immunogenic peptide, and it is a non-invasive. Neither you are taking blood nor you are doing biopsy. So either you do it in the stool or in the urine. So now this is the study which is done first time to show the correlation between the GIP and duodenal biopsy. When you do see the biopsy, more than 90% who are having negative GIP, they are having Mars 0 changes, means there is no villus atrophy. But those people who are having positive GIP in their urine, gluten immunogenic peptide, 85% of them had either Mars grade 2 or grade 3 villus atrophy. So it is a very good surrogate marker for detecting villus atrophy. So I don't. So to conclude, diagnosis of celiac disease, now it is possible to do without biopsy alone, provided you get an endomysial antibody test. However, intestinal biopsy gives you an opportunity to not only to confirm the diagnosis, but what I believe our ultimate goal of therapy is mucosal healing. That only possible when you have a baseline biopsy. Free gluten-free diet is the only therapy so far. There are some agents which came and disappear, like larazotide, or you have the TGP2 inhibitor, but they are not yet past the phase 3 trial. So we don't have an alternative drug for celiac disease to treat, and the patient can continue to take gluten. Maybe in near future we might get. Celiac serology has very poor sensibility to pick up poor complaints. It is finished. And probably GIP is the new player in the horizon who will tell you patient is compliant or not. Those PGs, they can go through this chapter in the PG textbook, given detail about celiac disease. And this is my last slide. I started my career in PGI Chandigarh, which is basically the center of celiac disease. This is the epidemic of celiac disease. Then I moved to Lucknow as the PGI. We used to get some celiac disease, maybe sporadic. Now I am moving to an institute, ILDS probably. I will miss definitely most of my celiac disease cases. Thanks.
Thank you, sir, for the wonderful lucid talk. Dr. Ajay?
Yeah, good morning. Sir, please stop sharing your screen. We welcome Dr. N.K. Arora, sir. He's the Executive Director of the Incline Trust International, and he was President, he is President All India Institute of Medical Sciences, Devgarh, Jharkhand. We welcome him. I request Dr. N.K. Arora, sir, please say a few words.
Yeah, thank you very much. Ujjwal, such a pleasure to see you after some time. It's really some time that we have met face to face. It was wonderful. In fact, I joined in between half of the talk you had already given, but it has given so many, I would say, ideas. Yesterday, and I would like to add 2 or 3 things. One is, and that we have been trying to promote in recent times, and that as part of our celiac disease management team, I think a psychologist is also very necessary, because along with trained dietitian you mentioned, I think that is very important. And just like all other chronic disease, whether it is we are talking about diabetes, asthma, all those things, it is like a storm for the family, and therefore a psychologist participation in the should be considered by our friends. The second thing I thought that the major problem with the disease is in the first 3 to 6 months when compliance issues come. And I think at this time, more for psychological support, if the frequency of contact with the patient is at 4 weekly interval, that would be helpful for improving the compliance. Third thing is that I think this country has now a large number of pediatric gastroenterologists who are having a good collection of or cohort of celiac patients. I think we should get together and answer some of these questions. In fact, you have raised 3 or 4 important research questions. Being on this side, I thought I will raise these 3 or 4 questions. One is that once we have diagnosed, I think this compliance issue, if 8 or 10 centers get together and follow and see what is the compliance, and using various parameters you have suggested and various strategies we have adopted during our clinical care to improve compliance. That is number one. I think that's, if we have a cohort of 5,000 to 6,000 celiac patients and we show their follow up over next 4 or 5 years in pediatric age group. So whether it is mucosal recovery, whether it is compliance related issues, or whether it is in terms of validation of new test like GIP, because I'm sure this is a very simple test. I'm sure it can be, I do not know whether it is available or not, but in today's technologically advanced Indian companies, GIP can very well be established, very established in the country. So with this, I again, once again, congratulate Ujjwal. It has been a learning exercise for me, and look forward for more such sessions. My heartiest congratulations to Shyam and the team who have started this podcast, and I'm sure it was so practical. It will be useful, and I will urge all pediatric gastroenterologists to attend this. Thank you very much.
Thank you, sir.
Thank you for your blessings, sir. I request the chairperson, Dr. Manoj Rawal and Dr. Baljinder Kaur, ma'am, to say a few words. Then we proceed to question answer session.
Thank you, Dr. Ajay. Dr. Padar, he has this was a very elaborative talk, and he has discussed all the things. And there was something which I was also not aware, and I will be following this in my hospital too. And I would like to attend further sessions also to strengthen my knowledge.
Sure, sir.
Thank you, sir. Thank you.
Dr. Baljinder, ma'am.
Dr. Poddar, a very detailed view of not only diagnosis, management, and also issues of compliance. Great session. Thank you, IIP Delhi, for making me a part of this. It has
Thank you,
been
ma'am.
a
Thank you so
learning
much.
experience.
Yeah. Thank you, ma'am.
Thank you, ma'am. Now I request Dr. Shamina and Dr. Shalja to please take up the question answers.
Sir, we have some questions from the participant side in the chat box. That the one of the audience said does any what about the dietary compliance related to oat in the diet in the celiac suspected case or confirmed cases?
Yeah, Sham, I just passed through this oat part. There is a basically problem of oat is in contamination during harvesting and processing. So recommendation is that when you are freshly diagnosing celiac disease, avoid oat for first 1 or 2 years, and later on it is permitted. Oat itself is not contraindicated, but contamination part is the issue. So oat is not allowed for first 1 year. After that, oat is allowed.
Okay, sir. Sir, one of the audience asked, what are the other causes of the villet atrophy apart from the celiac disease? And what time to repeat the biopsy for the mucosal healing?
Very good question. I was telling that you have to be careful making diagnosis in less than 2 years. The younger is the child, more chance of having villas. Dr. Aurora, sir, are you here?
Yes, I am very much here.
Sir,
And this is a very important question, and we look forward to your answer.
yes, sir. Thank you very much. I am honored, sir, that you are here, but you are my mentor. So we followed your the footstep. In less than 2 years, there are many other conditions which can give rise to villus atrophy. There is a this premier center, All India Institute of Medical Sciences, during Dr. Aurora's time and before that, they have done the biopsy, showed that most of the patients are not celiac. Either they have some kind of infection. We have persistent diarrhea due to infection, which causes the villus atrophy. We have nowadays, we started recognizing the food allergy, cow's milk protein allergy. You will get the villus atrophy. And older children, it may be the other condition like immune deficiency, giardia, malnutrition,
Sir, your
uncommon.
voice is intermittently coming down.
Oh, sorry. This is mainly the younger is the patient, more chance of having villus atrophy due to persistent infection, malnutrition, because of your food allergy, you get the CMPA cases, and the older patient may be some immune deficiency disorder or IBD or eosinophilic gastroenteritis. These are the uncommon causes. But remember one thing, if you get the subtotal villus atrophy in North India, it is almost equivalent to celiac.
Ujjwal, if I can come in and supplement to your answer. Are you still talking? Sorry.
No,
and
no,
I
please
thought,
go ahead.
yeah, the tissue monitoring is very important in our country for all the reasons you have mentioned. although with improving hygiene and less infections, I'm sure all of us are aware that diarrhea infection has gone down. There was, when we were growing up, it was 2 to 3 diarrheal episodes per year, per child per year. Now it has come down to zero point 0.2 or zero point 0.3 episodes per child per year. So there is hygiene and sanitation and all those. So there are things, but there are a lot of parasitic infections, giardia and others. And therefore, histological improvement is something we should not be shy. And as you have shown, it is in fact very stark reality that if histological improvement is not happening, the risk of malignancy is 3 to 4 times higher. And that is a very important information you have showed. And I think we should also build up a cohort to do such studies because we have now wherewithal to do such studies. And Meena, I would encourage all of you to do such studies together across the country. Over.
Okay. Sure, sir. Sir, one of the audience says, which type of the serological test is preferred, and why the not advocacy for the anti-endomysial antibody test in the early childhood?
Very good question. See, this is basically the technical feasibility. Doing endomysial see, the endomysial antibody is the best test because it is the most specific test. If it is a positive, it is more or less certain it is celiac disease. However, doing the anti-endomysial antibody test is cumbersome. You need the monkey's esophagus or human umbilical cord as a tissue, and doing immunofluorescent technique. It is a technically demanding. The person who is interpreting needs to be oriented for the type of endomysial antibody test he is saying positive or negative. So it is a technically demanding, and that's why it has gone out of favor. On the contrary, tissue transglutaminase is done by ELISA. It is a machine which will tell you it is a positive or negative, give you the titer. So it's a very simple test. It is a cheap, available everywhere. That's why we are relying on TTG. However, having said that, the specificity of TTG is not very good. And that's why recommendation is that don't rely on TTG alone. If TTG comes positive more than 10 times, add endomysial antibody, which is all become positive, then it is celiac, if you want to avoid biopsy. However, if you don't have the EMA facility, then go for biopsy. Sham is there to oblige
Yes, sir.
you.
Yes, sir. Yes, sir. Yes, sir. Sir, one of the questions, which one type of the TTG test is better, IgA based or IgG based?
See, obviously, we are talking about IgA test, not the IPO. A subset of patients who are having selective IgA deficiency, there you go for IgG TTG. Otherwise, it is a IgA test which is used for screening to look or to diagnose celiac disease.
Sir, what is the key message regarding the gluten challenge test for the general pediatrician? They can perform the gluten challenge test, or it should be only by the gastroenterologist or in the admitted patient?
No. This is a very good question. Say this is what we are talking about. Celiac disease is not a gluten allergy in general. When your worry is that when you do the food challenge, patient may develop anaphylaxis, right? But celiac disease, it doesn't happen. Celiac disease is immune mediated injury, but it is not IgA mediated. IgE mediated reaction is called wheat allergy. Wheat allergy is seen in less than 2 years of age group, like cow's milk protein allergy. There, it is a IgE mediated. If you have to give challenge, then you admit under supervision, keep the resuscitation, adrenaline ready, etc. For celiac disease, gluten challenge very simple. You can do it anywhere. Patient is at home. You need not to admit. You just fulfill the criteria. The age is between 7 to 12 years, not less than 7, more than 12. Patient is having baseline serology negative. Endoscopy, biopsy is normal. You put the patient on full gluten, ask him, khalo bhai, jitna marzi chapati. And then call the patient back after 2 to 3 months, ask the question, has he developed any symptom? Repeat the serology, is it positive or negative? Do the biopsy. The challenge is not complicated at all. No need for admission, nothing. It can be done by a pediatrician with the help of a gastroenterologist because you need to document biopsy changes, not only the serological change.
Sir, does any serological test help to differentiate between the celiac versus non-celiac gluten sensitivity or wheat allergy?
Good question. For wheat allergy, this TTG, EMA, it doesn't help. This is basically you need to do IgE specific anti-wheat antibody. Okay, anti-gluten antibody, IgE. What we are talking about celiac is, this is IgA or IgG, not IgE. So wheat allergy is a extremely uncommon, but seen mainly in the infant when you are talking about multiple food protein allergy, like cow's milk protein allergy. Second will be your soy allergy, and third is wheat allergy. So there, that antibody panel is different, right? But here it is a different.
Sir, one
And
of
for
the,
non-celiac gluten, Sam,
yes,
non-celiac gluten sensitivity is basically a vague umbrella term.
yeah.
It is becoming a popular in the Western country. All those IBS patients, they feel I stop gluten, I am feeling better, so I am a allergic. So almost 10 to 20% of general population in America and Australia, they are on gluten-free diet, but imposed by themselves. They self-declare that I am gluten sensitive. It's all rubbish crap. None of them have any of the antibody positive. So to diagnose non-celiac gluten sensitivity, you have to show this patient is not celiac. So TTG EMA is negative. This patient does not have wheat allergy. So his IgE panel is also negative, and his biopsy is not showing any villus atrophy. But he is showing improvement on gluten withdrawal. So then you suspect. And to prove this, he is having non-celiac gluten sensitivity, you have to do a challenge. Challenge has to be positive.
Sir, those are the biopsy proven cases. On the despite good compliance of the GFD diet, many children's that the extra GI symptoms are very well responded, but the GI symptoms still persist. How can we counseling or how can we take their cures in the day-to-day practice?
See, if the GI symptom persists, then one of the entity I said that the co-occurrence of other condition. Maybe patient is having IBS. Maybe patient is having problem with the FODMAP diet. FODMAP is this non-digestible disaccharide, monosaccharide, and polyol. So you need to just check which type of food is causing this symptom. So you can ask them, besides removing gluten, some of this food item, like what I said, that to start with, they have the lactose intolerance. So you stop the milk, they will improve. If the serology is coming down, hemoglobin is improving, other symptoms are improving, so it is unlikely that gluten is causing the problem. So maybe some other dietary component may be responsible. Or rarely you have microscopic colitis, bacterial overgrowth, chronic pancreatitis. These are not commonly seen in children.
Okay, sir. Sir, does any comments from the your side about the giardiasis and TTG test positivity?
Yes, I showed the case that patient has TTG positive because that false positive TTG is commonly seen when there is a underlying some kind of autoimmune condition, right? So and infestation. So these are non-specific antibody response when there is a autoimmune disease. So if you have a IBD, you can have a false positive, TTG positive. If the patient is having GRDI, it is shown that this can, but usually titer is not very high. This titer of TTG in other infection, immunity, autoimmunity, their titer is lower than what you see in celiac disease.
Okay, sir. Thank you, sir. Any comments from our chairpersons or expert from the NK Arora sir sides?
My one question to UJJAL is, can you please comment on the current fad? A lot of people are moving to gluten-free diet. What have you to tell them about this habit?
This is the story, sir. I was just highlighting about non-celiac gluten sensitivity, NCGS. So the 20% figure is nearly 20% of American and Australian people, they declare themselves as gluten sensitive and they are on gluten-free diet. There is a huge movement going on to say the gluten-free diet is a healthy diet that will protect your heart, protect your brain, protect your bones, everything. Absolutely crap, rubbish. There is no substance in it. There are studies to document most of these patients are having IBS and just more. This is not the gluten which is responsible. The other component of wheat which are not digested and causes symptom by fermentation. So the new concept is now FODMAP diet. The fermentable disaccharide, monosaccharide, polyols. There are many food. Wheat is one of them which contains the food FODMAP. That's why by withdrawing the wheat, they respond. But those patients who are responding, you introduce them pure gluten, they don't deteriorate. So there's nothing to do with the gluten, sir. These are all basically with age, our tolerance for many of these disaccharide, oligosaccharide goes down because our enzyme system become less efficient and we develop symptoms. So it doesn't mean that you should go for gluten-free diet. Gluten-free diet, highly expensive and it is not healthy at all.
Sir, what about the easily available gluten-free diet from the market product?
I am against it.
Okay, sir.
Because in
So
India,
one can
we
easily
don't,
shift to rice-based diet. Eat rice all
Mhm.
the time.
I have been
Yeah,
brought up in Bengal. I am eating rice 3 times a day. My colleagues from South, they eat everything made of rice. I don't think my brain, my heart, my body is weaker than North Indian people who eat wheat always. So,
Yes.
and
so
in
what I
the
advise,
Yes, sir.
Yes, sir,
Doctor.
Dr. Rahul, sir.
yeah, sir, what I advise to my patients, I have a lot of patients celiac with my in my hospital. So I say advise them that you should think that you have shifted to south or you have shifted to east and just stop eating wheat and your baby will be all right. And they
exactly.
follow this advice. They follow
I,
this
I,
advice.
I, I give them the comparison that you see how many IAS and IPS officers are coming from the south. They eat only rice. Rice खा के भी वो IAS IPS बनता है. I tell them they see me. मैं इधर हूँ लेकिन मैं चावल खा के बड़ा हुआ हूँ. तो फिर भी ये
Same,
प्रोफेसरेट
same, same.
बन पाया.
Sir, one of my friends is a endocrinologist in my city Rohtak, and I have seen advising him the people who are newly diagnosed diabetic in adult age, and he advising them that you should go for gluten-free diet, and the family is following gluten-free diet for their kids also. So the one of my his patients come to me that doctors have advised me my kids also gluten-free diet. What should I say to them? What should be done for them?
No. It doesn't make sense. There is a logic when it is a type 1 diabetes mellitus. Their chance of having celiac disease is high. This is the
Yeah.
co-occurrence of two autoimmune diseases. So almost 5 to 10% of type 1 diabetes mellitus, they can have celiac disease coexisting. That's why those are the patients should be all type 1 diabetes, you need to screen. You screen with
Okay.
CTG, not once, at least once positive, repeat it after 6 months, still positive, go for biopsy, prove it is celiac disease, start on gluten-free diet, their glucose control improve. But type 2 diabetes, there is a no relation between celiac disease and type 2 diabetes mellitus. And
Right, sir. Right,
family
sir.
screening for celiac disease is recommended. If one child is diagnosed, you can screen others. But for diabetes, stopping them gluten-free diet and whole family, it doesn't make sense.
Right, sir. Thank you, sir. Thank you.
Thank you, sir. As a closing remark from my side, definitely, as Dr. Arora says, celiac need the multidisciplinary approach, not only pediatric gastroenterologist, along with pediatrician for the regular follow-up, good dietitian, along that counselor or psychologist, because in the not only disease that affect the child that affect the whole family, because they need to change the kitchen. That the lot of the impact happened on the family life. So that's why the counselor or psychologist is very important for the management of the celiac disease. Uh, Message to our participant or audience: don't do the too much hurry to label for the celiac disease. It is a disease of lifelong. Child may require the lifelong gluten-free diet or till the definitive therapies come in future. So make the diagnosis very wisely, carefully, as per as available standard guidelines, and preferably make the diagnosis on biopsy based. After that, don't forget about the patient. Patient should be close follow-up and look the response of the GFD diet. If the child is not responding on the GFD diet, despite adequate good compliance, we should to relook our diagnosis. Thank you.
Thank you, Dr. Sham. But I think for the general pediatricians to have a high index of suspicion is very important.
Yes, sir.
Because celiac disease can mimic any disease, even tuberculosis. Because many such patients are first given ATT and then they are diagnosed as celiac. So one has to be very careful before starting even ATT empirically in such patients. You should have a microbiological diagnosis, and also please confirm, because once the disease is confirmed, then we have to religiously follow the gluten-free diet. So thank you, Dr. Poddar, for a wonderful session, and thank you all the delegates and respected faculty.
Thank you, everybody. Thank you for giving.
Thank you, everyone. Thank you so much. Thank you.
Thank you, sir.
Is Dr. Ravinder is here? Dr.
Thank you, Dr.
Ravinder?
N.K. Roda, sir, for your great inputs, and Dr. Baljinder Kaur ma'am and Dr. Manoj Rawal. And we
Sir,
request
Dr.
you to
Ravinder hai yahan pe?
CNI and your residents also for the paper presentation in the
Dr.
PC.
Ajay?
हाँ जी।
Dr. Ajay? Dr.
Dr.
Ravinder hai hamare sath?
No,
Dr.
he's
Ravinder?
not.
अभी तो नहीं।
Dr.
हाँ,
Dinesh
please,
put the closing remark. Dr. Dinesh put the closing remark, please.
Okay. So on the behalf of IIP Delhi, and we thanks everyone, and we are honored to have Professor Dr. N.K. Arora sir, Dr. Poddar sir, and our colleagues, Dr. Manoj Rawal, Dr. Balinder Kaur, and it is a wonderful session for the delegate. Hope everyone will be benefited. And our aim is to just percolate the knowledge to the delegates, the PG students, and the practicing pediatricians. And with this, and I thanks Dr. Meena also, and he has designed this module
Dr.
very
Shelja.
beautifully.
Dr. Shelja.
And yeah, Dr. Shelja also. And with this, thank you so much. And we'll meet you in the next session on next Sunday at 9 a.m. Thank you.
Thank you.
Bye-bye.